So congratulations on these achievements, and over to you.
Thanks, Amir. And I guess with great delight that Amir introduces me, having been one of my earlier PhD students, and I'm so proud to say a lovely friend. So today's talk is, I guess, a little different to the talks that we've had in the past. It's not particularly technical, it doesn't have really any computing in it, but it's more about a sort of a personal journey and a moment to sort of stop and reflect about why we do breast cancer research, what it means to the communities that we serve, and how we can better involve consumers in the design of the research that we do, and a little bit of a snapshot about how we're doing in radiology with involving cancer participants in clinical trials. So chapter 1, this is me as a breast cancer patient, and this photo was taken about 2 or 3 weeks after I had finished 20 weeks of chemotherapy. When I look at the photo, I think that I look pretty ill, actually. I don't know if I necessarily remember feeling so ill at that stage, but it's obviously not a great looking photo. I look very puffy, haven't really got any hair, haven't got any eyebrows. I didn't have any eyelashes, and actually I really didn't have any fingernails by that stage either. And I hope that none of us actually get to the stage where we look like this, but this is a very common reality for how most cancer patients look towards the end of their chemotherapy. So where it all began is that, like most radiographers in our training, we often say that we encourage patients to understand what their bodies look like. And in particular with breast cancer, we often encourage our women to think about whether they have a lump, whether they have a change in the size or shape of their breast, whether they have pain, whether they have a depression or a pull or a skin of the breast. And this is essentially what I had was, I had a bruise on my skin that didn't go away. And indeed, my husband said to me, "You've got a bruise that doesn't go away." And then underneath that bruise was a very palpable lump. And this is what it looked like. It is down here in the, I guess, 6 o'clock position. For those that like an ultrasound image, that's what it looked like on the ultrasound. It was about 2 centimeters big and fairly rapidly growing at that stage. And I think one of the take-home messages is that we often just think about a patient in isolation. So we say, well, this patient has come for a mammogram, and how would that patient's experience actually fit in with the range and extent of the medical imaging that in fact we do. And I guess what I just tried to do here up until the very last line there where it says yearly mammograms, DBT and ultrasound, is that those 8 or 9 points, they are all the things that I had certainly within 6 months of being diagnosed with cancer. So a bilateral mammogram and ultrasound as the original diagnostic scan. I was 38 years old at this stage. I had a core biopsy under ultrasound. I had a nuclear medicine bone scan prior to surgery. I had a sentinel node scan prior to surgery where they inject blue dye underneath. They inject the tumour, but they also inject another range of areas around the breast to actually pop that dye into the lymphatic system so that they can identify the sentinel node on that when you have surgery. I had a staging of my head, chest, neck and pelvis. After I'd had surgery, I then had an echocardiogram prior to starting chemotherapy because I had a left-sided cancer, which meant that I would be having radiation therapy to the left side, which meant that there is a reasonable chance that your heart is affected by the radiation therapy. I had a peripheral inserted central catheter in my arm on the right side, which was inserted under ultrasound guidance. And then prior to starting my radiation therapy, I had a CT simulation scan, including tattooing, and then yearly mammograms. And then when DBT became a thing, a yearly DBT and bilateral ultrasound. So I guess we often think about our patients as just coming and having a mammogram, whereas indeed they actually have a very large range of medical imaging. And indeed, some patients have even considerably more medical imaging in that, which might include things like a PET-CT scan and an MRI scan. And so most breast cancer patients have some surgery. They either have a breast conservation surgery. We used to call it lumpectomy, which is obviously a pretty horrible word and it's a bit nondescript. So now known as breast conservation surgery, where I guess perhaps up to half of that breast will be removed, or they'll have a mastectomy, chemotherapy, radiation therapy, endocrine therapy, immunotherapy, and some other therapies as well. This is a photo of me with my little one, who was probably maybe 5 by that stage. It was probably at a similar photo taken at a similar time to the first photo, because it's summer. And you can see that I've got the PICC line in my arm wrapped up, and I definitely don't have any hair in that photo. And so I guess thinking about, what most women would have as a standard therapy and how we can bring that consumer experience into our research. I had breast conserving surgery because the cancer was very close to the surface of the skin, and I had a sentinel node removal. After those sentinel nodes were diagnosed and my cancer was known to have spread, then I had a full axillary clearance as a second operation. I had 4 doses of what we call AC chemo, 12 doses. They were 3 weeks apart, which took me up to the 12 weeks, and then I had 12 weekly doses of Taxol chemotherapy. I had 30 fractions of radiation therapy, and I'm pretty sure I drove the radiation therapist mad with all of my questions. I was certainly probably the most informed patient they've ever had by the time I'd finished my 8 weeks with them, and I had 8 doses of Electron Skin Boost to the skin because the tumour was very close to the skin. And then I had 10 years of tamoxifen. So that's a fairly standard, bog standard treatment plan for most breast cancer patients. I guess what I didn't know, and what I think that perhaps we assume that our patients do know, is that there was a range of gaps in my knowledge coming to being a cancer patient, which perhaps you may assume that as a radiographer, I already knew about these things. And I had spent many years prior to having that staging scan, telling my patients about how it feels to have an injection of iodinated contrast and saying, you know, you're going to get a hot flush through your body. You might feel like you wet yourself. You might feel like you've had a stiff drink of whiskey. You know, you might feel itchy, whereas in fact, I'd never actually experienced any of those things myself. And within a very short period of time, I experienced, you know, a reasonable number of scans that include contrast. I'd never had a bone scan before I was diagnosed with cancer either, despite probably learning quite a lot about what those scans did and showed. Considering that my radiography education also included a first year of nuclear medicine as well. I think one of the things that maybe a lot of cancer patients will tell you afterwards is that they were very unprepared for the pain of the sentinel node injection. And I wish I had taken up the offer of a pre-medication prior to surgery, which might have knocked a little of the edge off of that injection, but it's an extremely painful procedure where they will inject dye into the tumour and around the breast and actually just underneath the nipple. And that's an incredibly painful procedure to have. And I guess one of the things is that I had read a little bit about this, but I wasn't prepared for how upset I would become every time I smelled the chemo each week. And this was something that patients often talk about. They have and develop an aversion to certain things. The cleaning of the PICC line and the smell of the chemotherapy drugs have a particular smell. And I would become over that 24 weeks very upset if I could smell any of those types of smells. In terms of, I've just coloured the bottom ones in terms of radiation therapy because these are things that I thought that I would have known a little bit about as well, but were sort of quite different, is that I didn't know how the immobilization would be done. I wasn't prepared for the large extended times that I was lying undressed on the table. I certainly wasn't prepared for the number of skin markings that they made on patients' skins, and they get the Sharpies out and they do lots of measurements and that sort of stuff. And it doesn't come off and it's really hard and it rubs all over your underwear and makes a giant mess. But as the days go on in terms of the dose and the fractions, they actually draw on you less and less, probably because you've still got the marks on you from the day before and they don't need to do as much. I wasn't really, someone that doesn't hear very well anyway, I wasn't really prepared for the sound that the linear accelerator made, and I didn't know what my skin would look like afterwards. But what I did have a sense of from having done a very large number of mammograms on women that had already had radiation therapy in my earlier years working as a radiographer is that I thought that this is what I would look like. And in fact, I didn't really look like that very much at all. So, but this person's obviously had bilateral mastectomy. So although I certainly don't advocate Googling naked yoga on your university laptop computers, this is sort of how I felt that I spent the majority of my time in radiation therapy, doing quite strange poses. But I think for me, the take-home message about being a breast cancer patient and then in later years somewhat a consumer representative is that my husband had very, very different thoughts to what radiation therapy was to what I actually thought I was having. And he was particularly concerned about the use of radiation therapy, that he thought, you know, it didn't seem to make any sense to have a therapy that was done in a bunker, for example. You know, we use these types of, we use the word chamber or bunker. He thought it seemed to be like an old technology, and you know, radiation is carcinogenic. And certainly that he thought that the radiation was very much second rate to the chemo. And I think really the take-home message here is that many consumers and support people perceive radiation to be very dangerous. And it's something that we probably, as people that have, worked in the discipline of medical imaging or work with, very, very powerful radiation therapy or medical physics background, is that we're very, very comfortable with this, and a very large number of people are not comfortable with it. So I actually wrote an article about this in 2015, and it took me a long time to write this article because I think that, I've spoken about this before, but when I had cancer, I couldn't bring myself to actually tell my children that I had cancer. So I just told them I was sick instead and that the medicine had made my hair fall out. And I think one of the reasons why I did that is because there weren't very many resources that talk about cancer patients becoming well again. Most of the resources that were available actually spoke about how to prepare children, talking from the parent point of view about parents dying or parents living with metastatic cancer. And there really was very little about how to talk to children about how you have cancer and you're going to be completely well again. And so it took me a long time to be able to talk to them about that. So, chapter 2. What are the many ways in which consumers can make valuable contributions to our research? If we think about ourselves as researchers, we really need to embrace the contribution and the co-design and the co-production that consumers of healthcare can actually make to our work. And I'm sure most of you are very familiar with Julie McCrossan, who about the same time, 11, 12 years ago, had a head and neck cancer. And she's just become a wonderful advocate for how cancer patients and their support people are included in decisions about cancer research. And I invite you to go and look at the Health Consumers New South Wales website, which is a really valuable place to check in ways in which you can co-design with consumers. And I think the reason why it's so important that we do that is because every lived experience is very different. So I guess, I've spent the first, 21 minutes telling you about my own personal experience, but it is very different to other people's experiences. And we've only really talked about breast cancer, but of course, all health consumers, but even that, there's a huge variety in patient experiences for all different types of cancer. So we often talk about this idea of cancer patients being extremely active in research around care, perhaps in regulatory approval, and within that spectrum of clinical trials. But I think it's also important to realise, and because the type of work that we do is around basic research and leading to those types of sort of pragmatic trials, is that it's very important for the consumer experience to be included in that early idea to basic research to clinical trial continuum, part of that, because there are many different perspectives and insights and co-design opportunities for us there as well. And so consumers as co-designers are very, very important. And I think one of the reasons why it's becoming more important, just simply from a logistics point of view, is that the research community really recognise the value of having consumers as part of your initial proposal. And indeed, there will be a range of ways in which that consumer co-design is scored or is evaluated. And so from the point of view of even, having the opportunity to conduct your research because it's been successfully funded, it's very important to think about what are the shared goals of the project in involving consumers. and what affiliation or designer agenda does that consumer bring. So you might have a consumer organisation, for example, like Men's Shed or Cancer Voices New South Wales, or the Men's Mental Health Unit, and they may bring a consumer as an advocacy group agenda, and then you may actually have individuals as well. You need to think about what would be the dissemination plan and how it can be inclusive so that consumers can also share in the dissemination, or indeed they could be actually taking a leading role in that. And then what will the research impact of your co-designed work look like? And how can other people connect with the research designers that are going to be consumers? And then how co-designers make that project very authentic. So that there are very different types of co-designers in health. And so I guess I've spoken a little bit about myself and what the lived experience of a cancer patient brings, but health consumers actually encompass a very broad range of people. So they could be people with lived experiences in terms of they could be carers, they could be patients themselves, they could be clients of a service such as the NDIS, they could be end users such as clinicians, they might be students, industry partners, whether that be corporate or government, and then also our NGOs such as charities, community groups, but also you may have a co-designer that is a very distinct population. For example, if you're doing work that has a very important culturally and linguistically diverse element to it. And so in designing resources and accessibility and co-design, you have to be very mindful that all of these things need to be captured or at least thought of until you narrow down your project. And you also need to think about how your co-designers fit within an academic system. So many co-designers are actually outside or could indeed be alienated from an academic system. They might feel like there is a power imbalance there. They're not able to effectively engage with the research that's cocooned within an academic or research system. And so there are a range of strategies to help with that. So I just want to draw your attention to statements from the NHMRC about common elements for co-design in research. And they're really about effective involvement in consumer decision-making and trust and respect for all of those parties. They talk about having a very accountable and transparent approach to the research outcomes and how they're actually reported to consumers. So often, for example, when clinical trials are starting to perhaps unravel or not take the original direction that the research was funded in, we often don't explain to consumers, or we try and shield our consumer co-designers away from that output. And I think it's important to be very transparent about why the research direction may have changed. And the NHMRC also recognised that there's a series of best practice elements here for co-design and inclusivity, and that is about how consumers will be involved in all stages and levels of the research, and that recognising the value of consumers in terms of having budget line items for how those people are valued from a monetary sense or from a reward sense of, or how from a recognition sense into also in terms of IP, how there will be development and of standards around criteria and scoring of the consumer involvement. And you'll see a lot of grants these days will ask you to write the grant, and then they'll also ask you to have a consumer section that may be written by the consumer themselves or the co-designer in that. That consumers are often now full members of grant review panels, or indeed it may go to a separate consumer panel for a scoring. and that there should be provision for training and funding for consumers to implement the consumer involvement. This is just a chart that essentially shows you the different levels of participation, and it's pretty busy, so I'm not going to go through it too much, but it talks about, obviously the apex of the triangle being research that is consumer-led, and very, very limited amount of research is actually led by the consumer. But we see in recent years some MRFF schemes that are clearly labelled consumer-led, targeted research into XYZ. And indeed, our university here in Sydney has been very successful with those types of large grants in the last couple of years. And then it sort of cascades down into partnerships involving consulting and then informing. So really at that information level, that is our most basic form of involvement of consumer capability and organisational capability. So a couple of take-home messages here. How can we maximise consumer and patient recruitment? And so what I've just tried to do is have a bit of a dive about how well we're doing in medical imaging in terms of looking at the way that we involve consumers and indeed patients in clinical trials in medical imaging. And there's a couple of take-home messages here. And really the first one is that the technology that we use often moves at a speed faster than we can do the clinical trial. So we're often trying to retrofit the clinical trial to the technology. We have very, very few prospective trials that we undertake. And indeed, even with very new technologies such as AI, the majority of the articles that are being published at the moment are really a retrospective analysis of that. And the second thing is that we're not doing a very good job of selling medical imaging clinical trials to our patients in our community. And there are a number of things that we can do to assist with that. So here's just a couple of articles that you might like to go and have a read of. But essentially, it does a sort of an analysis of what factors actually influence patients to be part of clinical trials. And in this case, we looked at a couple of clinical trials. One was around CT. And another one in clinical, a cancer trial that involved a large amount of medical imaging. And the types of elements that weighed in towards whether there was successful patient participation in those medical imaging trials was that those that opted in to the trial had an altruistic benefit. So they considered they were making a really good contribution to understanding around knowledge impact, and they would like to be part of the trial for that. Others also felt that they were getting free care that obviously they may not have been avail of. And there were concerns though around the use of contrast, which I guess coming from the sort of background where I have been a breast cancer patient, actually that just seems to be the smallest amount of everything. But the articles actually show that contrast use consideration is quite high as opposed to as a factor about whether patients might like to participate in medical imaging clinical trials, and also the provision of pre-medication prior to undertaking that particular type of medical imaging, whether it be something like midazolam for claustrophobia for an MRI trial, or whether it might be something like beta blocker for cardiac scanning. The concern around radiation dose was high, but not significant between those that said that they did or would sign up for a medical imaging clinical trial versus those that had decided that the clinical trial was not for them. So they both had similar concerns, but it wasn't really a deciding factor. But I guess one of the key elements here was that there was really mixed views on randomization. So often patients in general felt cheated if they were assigned to a placebo or and or they felt that they were not being offered what they thought was a superior medical imaging routine. So that the fact that they may get the standard care was often considered to be a detractor from participating in that trial and just signing up and being part of the control group, as opposed to being imaged with a newer modality. And they obviously, a number of them obviously felt like that they were, a guinea pig within a clinical trial and felt that they had a lot of control over what would happen depending on what group that they were assigned to. In terms of medical imaging clinical trials, so this is just a quote taken from the article there that you can see, but the patient's attraction to a particular study design and essentially what we're doing with the phase contrast tomography clinical trial is really a test of non-inferiority. So we're trying to determine whether one medical imaging technique is less inferior than the standard of care, and happily, those show higher recruitment rates than the placebo-controlled ones, which meant they would have no imaging at all. Randomized clinical trials and prospective trials are obviously a higher order evidence, but they also are considerably more costly to run. As a general statistic, 50% of clinical trials fail to recruit the original planned sample, which obviously then limits their ability to perhaps translate to a wider audience or indeed reach the deliverables which the grant was based around. This is just a graph that I wanted to show you, and it essentially shows you that the number of prospective clinical trials in radiology is decreasing somewhat over time. So from 2009 to 2012, the grey line just shows you all of the research, and the orange line is the number of prospective clinical trials that are conducted. And so we're actually starting to see a decrease in the number of this type of research that we do in medical imaging. I was sort of reading a little bit more about this last night and sent Jenna a whole heap of articles on it. And some of that was starting to attribute in the later years to the rise of AI and the number of articles that were actually published around 2016 and upwards that looked at AI as being the primary modality, if you like, that was being studied in radiology. All of those were largely retrospective, which starts to tip the balance then into having, I guess, less focus on prospective trials. Prospective trials obviously take longer as well because you need to follow cohorts through. So we're starting to see some downward trend there. And I guess what factors need to be considered, and this is a lovely article written by our own Yabeli Jimenez, who looked at a study in the Sydney area of radiation therapy clinical trials and why some had been successful and others not. And essentially, there were three key sort of themes here. One was that the patients were had a perception that the burden of being involved in a medical radiation clinical trial was too much for them to then volunteer to be part of. They were either felt that they didn't have the time to be involved in that trial, or because they were indeed cancer patients, they were too anxious about their own personal health to be involved. The second one is around the perception of the burden of recruiting practitioners. And we know, for example, within our impact research that Jane Fox has led the recruitment of patients to give tissue samples in this area. But in this case with radiation therapy clinical trials, it was felt that the clinicians had very limited time to discuss the study with the patients to be involved, because radiation therapy is a very complex therapy, and they wanted to spend more time with their patients and the support people around them discussing the outcomes of how radiation therapy works, or that they felt that they were coercing their patients into participating in that trial. And I guess an element of regret around doing so. And the third one was about protocol limitations and features. So I know from supervising Yabeli that one of the key elements for involving patients and support in our study of the use of VERT simulation to help breast cancer patients complete their radiation therapy is that it's very difficult to have a range of resources that match the culturally and linguistically diverse population of which you're recruiting from, and that randomization is not well comprehended by participants. And that really links back to the earlier papers that I've referred to, in that patients feeling that the process of randomization actually in some ways contributes to an inequity of their treatment, and it then manifests in an anxiety. And this is just actually a quote from Yabeli's paper, but we need to be able to thoroughly explain to patients why they are part of the clinical trial, and what a randomized study design actually means, and what we can glean from people's involvement in being part of a control group, as opposed to receiving a new type of medical imaging, a different type of radiation therapy, a different cancer drug that they may get. And this is me last year with my very photogenic pug. Obviously, I'm completely well. I'm very grateful for everybody's support and the people that cared for me throughout my cancer journey. And I am definitely one of the very lucky people that has passed that 10-year survival rate with flying colours, and now hope to support other people as well. And that's it from me.
Thanks a lot, Sarah, for a very inspiring and insightful presentation. And I think it clearly showed why it is important to involve consumers, and it's not just ticking a box for submitting grants. And we need to deeply reflect on this, particularly for the impact project. So let's open the floor for questions. We have lots of people online as well.
One can see all the people, even though I choose gallery.
I think you only see the ones with video on.
Oh, okay.
But I can see we have
Yeah.
people.
Can people, every people turn on your video so I can take a photo, because this is the most many people attend the seminar. Great.
There you go.
Okay, great. Any questions, comments?
Oh, I can ask one.
Yeah, sure.
Thank you very much for the talk, sir. It was really nice to hear all the aspect of the journey. My cousin, about around the same age, she was diagnosed with breast cancer as well, and thanks God she's fine now. I was gonna ask about how do you find that the aftermath section, if you like, yes, I had cancer, yes, it's gone, but we have this expression in Persian that if you have been bitten by a snake, then whenever you see a string black and white, you'll be frightened. So
Yeah.
how do you describe that part and information around that and support for people at the stage?
Look, I think, maybe I'll just invite Cindy to add in her perspective here as well. But I think that there's a lot of research around the fear of recurrence. So indeed, the School of Psychology here at the University of Sydney does a really marvelous job of researching that particular thing. And I think that some people live with considerable anxiety of that snake, coming back. And it's a difficult thing to measure, I think. And I realized actually halfway through the talk that I was using the older set of slides that I hadn't, I added in a couple more this morning to help explain something a little bit more. But I think it took me, the slide that was missing out of there detailed the studies that people had asked me to be part of that I just said no to. And I felt like I couldn't do that. And one was trialing a drug to prevent bone metastases. And it was incredibly involved. And it meant that I had, I think, 3 years of monthly blood collection. I had to take, I was assigned randomized to a group, so I didn't know what I was going to have. I think I had to have an OPG, so a dental x-ray every 6 months, and 3 bone scans through the 3 years. And actually, I just felt that I needed to walk away from that part of my life. And I didn't want to be, once I'd finished my radiation therapy, I didn't want to be tied to another 3 years of cancer research as a cancer patient. And I said no to that. One of the and it was that was I guess probably was to the researchers, it was very disappointing because they needed to recruit women that were under 40 to the trial. I spent a long time thinking about it, and I just felt I was too time poor and maybe too anxious to be part of it. But the things that I have done in the future since then is I've been part of chemo brain studies, although I don't actually think I suffered from chemo brain. I've been part of studies that have looked at, I guess, self perception of aesthetics after cancer, such as surgical sites and skin discoloration, and I've been part of that. And actually, the thing that probably I'm most proud of is I was part of a study that put together a range of resources for parents to talk to their children about living with cancer and becoming well again. And they're the things that I did say yes to, but it took me a couple of years to be able to do that. Cindy, I'm not sure whether you felt like you might like to share your experience. It's probably...
Thanks, Sarah. Yeah. First of all, thank you for being so generous in sharing your personal story with your colleagues. I think that was a wonderful thing to do. So thank you as a consumer. I think it will be a benefit to not only to me, but to everyone who's participating. Gosh, there's so much. I mean, and you mentioned there during your session about the chemotherapy and the smell. I still react to that. And I had chemotherapy 15 years ago. Even the thought of it brings on the sense of that smell and the nausea that comes with it. And I definitely have got chemo brain. I love that analogy of the snake and the recurring snake. I think that's a beautiful description. And there's even an acronym. It's FCR, fear of cancer recurrence. And I can quite understand, Sarah, your comment that you didn't want to be necessarily involved in some of those projects that I'm sure you would have been a wonderful participant for, because it just reinforces the diagnosis and the treatment and can sort of hold you back from moving on in some ways. So I think that was, I can quite understand your comment there. I guess I would just echo everything that you said. No wonder you and I can relate so well, because we've obviously had some very similar experiences. I'm not sure what else I can add, but except thank you.
I think one of the things, just to tie that final thing off, is that it's not just actually about you as the cancer patient. And I think a lot of times there are a lot of trials out there that look at the role of the family unit or the support person. I think for me, my lovely Darren, he didn't want me to be part of those trials either, because I think that he wanted to move on from that. And that, I say that in a completely unselfish way, because it had been a pretty horrible sort of 14 months, and he felt like as a family we didn't want to sit under this umbrella of me looking or being ill or constantly going to medical appointments to be part of different clinical trials. And so what I have done in the future and in recent years is actually stuff that really only impacts me as a person and doesn't impact upon my boys or Darren in terms of the time it takes me to volunteer for things, because not that they are ungenerous people by any stretch of the imagination, but I think for him that was a way of him dealing with his anxiety, is for us to move on.
On a slightly different note, and you referred to it at the end, Sarah, with the culturally and linguistically diverse issue. Well, one of the criticisms often levelled at the development of AI algorithms is that it widens the gap between the advantage and disadvantage, because the data you're gathering are generally from more privileged people, because they come to the hospitals and they can afford to, and so on. I wonder if it's possible that the same thing could be happening within consumer organizations, that you're getting the opinions of the more privileged people. And I'm sure the consumer organizations are very aware of this, and I'm just wondering what they're doing to try and address that.
Yeah, I mean, I think that that's really, really important. And actually, my role as Associate Dean of Research Performance actually developed a toolkit. So for those of you that are Sydney Uni staff members, it's on the research pages about involving and different ways to have consumer participation from what I call the voice less heard. So actually, in developing this about 18 months ago, somebody from our school actually said to me, "You are the typical consumer that we always hear from. You're white, you're blonde, you've had breast cancer, and you're affluent." And there were a number of people in the room that were very upset that that person said that to me. And you can afford to volunteer. And yes, maybe it wasn't said in the nicest possible way, but it was completely true. I am the sort of person that can probably afford to do that. And there are many people that can't, and there are many people that can't be co-designers of research because they can't afford to, they can't take time off, they don't have carers, they can't read the participant information sheet. And it's particularly prevalent in a number of clinical trials that might relate to things like mental health or disadvantaged groups. So I don't have an answer to that, but to say that I think when you're thinking about consumers for co-designers, we often say that the consumer is the voice that's not heard, but there are actually layers of that, and it's the consumer of the voice that is probably least heard that's perhaps the most important. Cindy?
Yeah, absolutely. Patrick, the meeting we had last week at Melbourne Uni, I actually made the same observation as well, that the consumers are white, middle class, Anglo, and it's absolutely an issue. And I guess I know that different organisations try very hard to try and broaden the range of consumer consumer representatives. I guess one way of improving it is people like me who can reach out to other, as much as one can find, to actually try and get that voice of other perspectives. But it is, as Sarah said, very much compounded by, is there even an awareness amongst other, amongst sort of diverse communities that there are even these opportunities? So the messages aren't necessarily even getting out to potential other consumer groups, profiles, other consumer profiles. It absolutely is an issue. And I guess another thought is that as a consumer, one needs to think very broadly about that much broader demographic than just one's own little sort of comfort zone of people that look like, sound like, educated like me, which is, I guess, part of the challenge of being an effective consumer rep, that you do need to have that much broader awareness and be thinking about it and trying to encompass those other perspectives as much as one possibly can. It's very imperfect though.
Is there any other comment or question? Probably not. So thank you again, Sarah, for the presentation, and again, best wishes for the next stage of your career.
Thank you. See you. Bye.
Bye, everyone.
Bye, everyone.
Thank you very much, Sarah.